very good evening to all the participants, and we are very lucky to have two versatile personality with us today, Dr. Radharani Ghosh and Dr. D.N.SHARMA sir. Everyone knows him very well. So for moderation for this 12th online class under the banner of UP chapter AORI, I would like to invite Dr. Radharani Ghosh ma'am. She is the Senior Consultant Radiation Oncology, Kamla Nehru Memorial Hospital, Prayagraj. Ma'am, it is over to you.
Thank you, Dr. Surabhi. It's really a privilege to have Dr. D.N.SHARMA here with us today to deliver a talk on brachytherapy in head and neck cancers. Dr. Sharma, as you know, is the professor and head of Department of Radiation Oncology, AIIMS New Delhi, and National Cancer Institute, Jhajjar. He's the Associate Editor, Cancer Research and Therapeutics. He's the Vice Chairman of College of Radiation Oncology, and he has over more than 200 publications to his credit. He is a leading international expert on brachytherapy. It is really a pleasure and a great honor, sir, to have you with us and to deliver a talk on brachytherapy in head and neck cancers. And I'm sure we all are going to have a feast on your presentation. So over to you, sir.
Okay. Thank you, Dr. Radha. Thank you very much for the warm words. And thank you to Surabhi. Thank you, Dr. Asi. Thank you, UP Recon, for having me here on this platform. It's always a pleasure to speak on brachytherapy. You know, on any given day, if I don't perform brachy or don't speak on brachy, there's something's wrong. So I don't have dinner on that night. You know, so every day there has to be something on brachy. You know, so thank you once again. And I'm going to speak in another 40-45 minutes the role of brachytherapy in head and neck cancers. And just to introduce, head and neck cancer are very common in India. You walk in any OPD, you will find several patients flooding the OPDs. You know. So it is one of the common cancers in India. And we all know that majority present in the advanced stages, where the brachy role is not much, but we'll see that even in advanced stages, brachy has a role. But despite the fact that majority present in advanced stages, a sizable number of patients still come in early stages, you know, where the brachy has a principal role. You know, the head and neck region is a region which is having a several organs closely abutting with each other, having different functions, diverse functions, which are very vital to the body. And therefore, organ presence is very, very important in the head and neck region because every organ has to perform some function. You know. And whenever we talk of the organ presence, then we have to choose an important modality in the radiation therapy itself, which can preserve the organ. You know. And when you talk of all the modalities in the radiation therapy itself, the brachy is the most conformal technique. You know. So therefore, we must choose wherever there is a role, wherever there is a indication, we must choose and perform the brachytherapy in the head and neck cancer. You know. So these are the various modalities for the radiation treatment in the head and neck cancers. You can divide into action beam and the brachytherapy. In action beam, we have conventional RT, then we have IMRT, we have IGRT, we have VMAT, now we have proton beam therapy, and then brachytherapy. But I'm showing this slide because majority of the progress has been taking place into the action beam radiation techniques. You know, the brachytherapy has not seen much advance, maybe because it is so conformal right from the beginning that it doesn't need much advance. But even then, now off late there have been a couple of advances, especially. Just a minute, I just. Okay, so relatively, brachytherapy has not seen many advances as compared to the action beam treatment. This is just to show that this is the head and neck region. This is just to show that how closely the organs are packed into the head and neck region. You can see all these organs, the vessels, the muscles, the cartilages, the tongue, the organs of speech, smell, and there are different organs which are tightly packed. So even you need a modality which can be very conformal. The dose follow-up must be very sharp so that the adjoining OR gets the very, very less dose. At the same time, tumor gets the highest dose. So in these kind of scenarios, you will have to choose a modality which is very conformal, very precise. And just to show you, the head and neck region has many diverse functions, which is very vital to the body. For instance, smell, the taste, speech, sight, and cosmesis. So therefore, organ preservation is very important and very vital in the head and neck region because there are different functions located in this small area. And therefore, there is a damage to some organ, either because of surgery or because of some other treatment, then that concerned function will be gone. and patient will have a compromised quality of life. So therefore, you'll have to choose a treatment modality which can preserve all these functions, at the same time can give a high local control. And brachytherapy is one treatment which can serve this purpose. It can give a very high dose to the tumor. At the same time, it will give a very small dose to the adjoining OAR, and therefore not compromise the quality of life. So therefore, brachy is the treatment modality of the for radiation treatment in the head and neck cancers, if it is possible, if it is feasible, and if it is doable. As I said, of all the radiation techniques, be it proton beads, BMAT beads, IMRT, brachytherapy is the most conformal technique for the radiation delivery. This everybody must understand, especially the youngsters. They should understand that despite the fanciness of the modern X-ray beam techniques, brachytherapy still is the most conformal. In fact, I would say it's the mother of all conformal treatments. It gives a very high local control and minimal side effect. Therefore, you call it has a very high therapeutic value. And we know we can preserve the organs, unlike the surgery where we sacrifice the organs. In brachytherapy, you can preserve the organs very well. And the best part is that it is a short treatment. It's a very quick treatment. You can deliver the same dose in 7 days, which you deliver in like 7 weeks. I'm sorry, it is written 70 days, but it is 7 weeks actually. So it is a 10 times less time taken for the brachy delivery for the same kind of equivalent dose. And it is cost effective because you need a small machine, unlike the VMAT or the proton. It is a very small machine which is not very costly. So therefore, this treatment is cost effective. You need a treatment which is takes only 7 days, so you don't have to admit the patient for a long time, unlike in surgery where it can take time. And unlike EBRT, it's a very brief treatment where you can just have a small portable machine and you can do the treatment. So therefore, these are all attractive features of the brachytherapy treatment in the head and neck cancer. Now, many people think that head and neck brachy is very complex, very complicated, very skilled, very difficult. And this is one principal reason that people do not choose head and neck brachy, because they really get fear that we'll end up in some complications. But let me tell you, head and neck brachy is not very difficult because of the following factors. First, head and neck region is an easily accessible site by the naked eye and your digital examination. You can palpate, you can auscultate, like if there's an underlying vessel near the node, so you can do auscultation as well. I mean, this is amenable. One site is amenable to all sort of examination, like naked eye and the palpation and auscultation and all. Unlike in thorax, where if you have to perform a brachy in thorax or the abdominal region, you don't have anything to palpate or the naked eye examination, or like in brain. So therefore, it is an easy accessible site, anatomical site, where you can see, you can palpate, and you can do all sort of examination. As evident in this picture, most of the sites like lip, buccal mucosa, palate, the anterior tongue, the base of tongue, hard palate, all these are amenable to the naked examination. And this just to show, this is one study from India, although there's studies from abroad as well, but this is one study. I thought let me just quote an Indian study from the Hyderabad, where they compared the interstitial brachytherapy with the IMRT, just to see that which one is better, because most people nowadays think that IMRT will definitely be better. They presume so, that IMRT will be definitely better than brachytherapy. But in this study, they have taken 15 patients and they were created two plans, one IMRT and one ISPT. The tumor coverage or PTU coverage was same with both, but the OAR dose was significantly less with the interstitial brachytherapy. So therefore, this is just to show that brachy is much more precise, accurate, and conformal as compared to the IMRT. Coming on to the indications of brachytherapy in the various head and neck regions, it can be performed alone, which means either a sole treatment or a definitive brachytherapy. This is mainly for small tumors, T1 tumors and the small T2, early T2 tumors in general, although it varies from site to site, but usually T1, T2 tumors can be covered by brachytherapy. And it can use for boost for T3, T4 tumors, where you can combine EBRT and then brachy for the boost. And even for small tumors where you find that definitive brachy or brachy alone will be difficult to perform, then you can do the boost and combine with EBRT. So brachy has a role in T1, T2, T3, and T4, all tumors in different formats. And it can be used in adjuvant treatment with surgery, like for recurrent tumors, you can do surgery, and there and then you can do like intraoperative brachy or perioperative brachy. And even after the surgical, if the surgical margins are positive, you can insert a plane of catheters to deliver some dose if the margins are plus minus positive. So it has different roles in different sites. These are the various site-wise indications, like right from the lip, floor, mouth, buccal mucosa, anterior tongue, gingiva, base of tongue, nose PNS, nasopharynx, neck node. So almost every site is amenable for brachytherapy except like piriform sinus and maybe the below the base of tongue where the approach is a little difficult. But otherwise, most sites are amenable for the brachytherapy. There are few relative contraindications like lesions close to the mandible where there is chance of mandibular necrosis, but of late that contraindication has been not to be considered, because with SDR brachy you can really titrate and scalp the dose there. So there is no fear of the mandibular necrosis because you can measure the dose at the mandible with the CT base brachy. And or there any other critical like a vessel, a big vessel, or any other where not the dose, but in fact the trauma to the brachy might be a risk to the big vessel. So there might be small relatively contraindication. Cases having trismus where you can't put your finger or you can't see the lesion, so that becomes a relative contraindication. And any other site which is not accessible by your finger or by your eye examination, so that becomes a relative contraindication for the brachytherapy. This is just to show the literature. I will not go in details of literature because I think mainly it is for the benefit of the youngsters that they have to understand the principles of brachytherapy in head and neck region rather than go into details, because I know most youngsters nowadays will like to go for literature. They will quote literature, they will quote studies, but I will not go in details because otherwise there no dearth of literature. There are plethora of publications in the head and neck region, but just to show you that people think that, if you can see here, people think that in T4, T3, T4 there is hardly any role of brachytherapy. But let me tell you, there are studies which are principally confined for T4, T3, T4 tumors. As you can see in the red box, these are the percentage of T4 tumors in the concerned study. Like in 17 patients in this series, 17% had T4 tumors, 17% I would say, 16%, 24%, and in this, in fact, 56% patient had T4 tumors. 60%. So it's not that in T3, T4 tumors you can't perform brachytherapy. In fact, that is where you need to escalate the dose beyond 70 gray, which you can't do with conventional EBRT with IMRT or VMAT, whatever technique you name. But you can't go beyond 60, 70, 75 gray with these techniques. But with brachy, you can go up to like 90 gray, 100 gray, because it's very, very conformal and the dose is deposited very densely into the tumor region. So therefore, in T3 tumors, there is a much more indication for escalating the dose if you want to have the local control and the cure rate as good as like in early stages. So there is no dearth of literature for the role of brachy, even for in T3, T4 tumors. So this was just to show that. And if I can, there are people usually nowadays will like to follow the guidelines. Well, there are plenty of guidelines for head and neck brachytherapy. This is one Jack Estro guidelines published in 2009. If somebody wants to just go through this, I will not go in details, but just to name a few of them, Then we have ABS guidelines, American Brachy Society guidelines, published in 2016. Okay, so they were for like tongue tumors and other head and neck sites. Then we have update of the same Jack Estro guidelines published in 2017, not long time back, So we have, from time to time, we have been having guidelines for performing brachytherapy. It's only that people should be ready to take these guidelines and perform brachytherapy, So, and after that, now we have IBS guidelines, Indian Brachy Society guidelines as well also. So there's no shortage of the literature. It's only that we have to just take this up and start performing the brachytherapy, So this was also published like 2019 or 20, I guess, So it's not a long time. So we have plenty of guidelines even from our own country as well, And this is one literature study where I would like to quote, that people think that head and neck brachy is dying. People usually have that sort of opinion. So there was a study conducted in the United States in 2016. It was published in Brachytherapy Journal, and they had the same notion that brachy is decaying of late. So they did a survey-based analysis amongst their own centers in the United States, and they found that during the period of 1973 to 2012, they studied the pattern of brachytherapy being performed over the years, and they found that during this period, some 5,000 old patients were treated by brachytherapy, and they studied that the brachytherapy use declined by 0.58% every year. and it was significant. So there's no doubt it is going a little down. There's no doubt of that. But the startling or the amazing fact was that when they analyzed these patients who were treated with brachy and without brachy, they were stunned that the patients who were not who did not receive brachytherapy, they had a significantly inferior survival. As you can see in this graph, the patients who were treated by the brachy or brachy plus EBRT, they have a superior survival even at 30 years survival. 30 years period in head and neck region is not very small period. So and if the patient who received only EBRT, they had a significantly less survival even at 30 years. So there's a significant difference between the survival in the patients who were treated with brachy and the EBRT. So you don't need any other literature, although it's not a randomized clinical trial, but this sort of study, with a follow-up of 30 years, is a significant, study, I would say. And as you can see, P-value is significant. P-value is less than 0.001. And this is a forest plot analysis of the same study, and you can see across all the the subgroups, the brachy had an advantage. For example, in different age groups, brachy was better than EBRT. In male, female, race wise, then year wise, like people think that earlier brachy was not very advanced, so now that time the results were inferior. But even at that time, brachy had better results than EBRT. And the various subsets, like even in oral cavity, and the almost oral cavity, different, like tongue, floor, mouth, alveolar region, lip, buccal mucosa, across all these sites, subsites, the brachy was better. Even the grade wise, tumor wise, tumor size wise. So across all the subgroups, brachy was definitely better than the EBRT. So I think this is a very important study, which you must keep in mind, that if you do brachy for head and neck region, you will get better results. There's another study which was published not a long time back in head and neck journal in 2019, where they had a similar sort of a survey in the United States. This is one of the from centers from the Bahman Imami from the Chicago. And in this, they also studied the effect of brachytherapy in patients who were treated by brachy versus brachy plus EBRT. As you can see again, patients who were treated by EBRT plus brachy had better survival, and the patient who were treated by EBRT alone, you can see the lowermost Kaplan-Meier survival curve, and this was across 100 months. Something like 8 years. So this is also long. 8 years is a long period in the head and neck, because mostly they will fail in 2.5 years. So 8 years is a good time. You can see as good as like 10 years, and the p-value was significant. So here also that this study showed that brachy group had a better survival as compared to the EBRT group. Anyway, but that was just a literature, just to update the youngsters. And coming on to the techniques of brachytherapy, now there are multiple techniques. You can in fact perform all sort of techniques in head and neck side based on the site which we are treating. We can do surface mold brachy mainly for the superficial lesion like lip or the skin or basal cell carcinomas. You can do intraluminal or intracavity brachy for nasopharynx, and you can do interstitial for like tumors having the substance like tongue and base of tongue and other tumors. There are some of the general principles of brachytherapy. I will not go in details, but these are some of the basic principles. First, the patient should need to be counseled, just like we counsel for surgery. In the same way we counsel for brachy, that the organ will be preserved, but you will have some, you have to stay in the ward, you'll have some pain, but we'll take care of the pain. So you can clear all the doubts from the patient's mind so that patients are comfortable while undergoing the brachytherapy. It should be done in general anesthesia. If the tumor thickness is less than a centimeter, you can perform one single plane implant. Otherwise, you have to do a multiple plane implant. And then when you do brachy, demarcate the area and then take around a centimeter, 1 to 1% all around the lesion, so that you can cover the microscopic disease as well. Distance between the two planes has to be like 1 to 1.5 centimeter. I usually keep that distance. I do not keep 1 centimeter, because if you keep 1 centimeter in interplanar distance, then you have to end up then you have to put more catheters, which I avoid, because head and neck is a very vascular area. The more needles you put, the more is the risk of the hematomas and the bleeding and all that. So you should choose a distance in such a way that you do not end up putting more catheters. So I usually take 1.2 to 1.5 centimeter intercatheter and interplanar distance. And therefore, as I said, avoid too much of trauma. And do not hesitate if you need a surgical, because sometime when you're doing brachytherapy, there might be some bleeding from the tongue if you're doing a tongue implant, and that can be sometime that might look scary, but I think so one should remain cool, and if not controlled, then one can call the surgeon at hand so that they can just 1 second. Dr. Rama, I'll just call you back because I'm in a lecture. I'll call you back in 5 minutes. Okay, fine. Sorry. Okay, then this is how the dose prescription is recommended. If you're doing brachy alone for like T1 or early T2 tumors, then the dose has to be like in the range of 60 to 70 gray if you're doing LDR. But I guess a lot of people have abandoned the LDR brachy. So an equivalent dose of like 45 to 60 gray by high dose rate should be given, and 3 to 4 gray in one per fraction in 2 fractions a day. So that was for definitive brachytherapy. For boost, 20 to 30 gray based on the tumor size and the site. If you're comfortable, then about 20-25 gray should be definitely given, so that the total cumulative dose might become like 80-85 gray. Intraoperative dose usually around 10 to 15 gray based on the situation, that if the margins are negative, then the like maybe 12 gray is sufficient. If the margins are positive, then the 15 gray plus might be the dose recommended. And for recurrent tumors, it will be a variable dose because it will depend on many factors, like when was the previous radiation given, what was the technique of radiation in the previous setting, and how much is the DFI, and what's the tumor size. So there are so many factors. So you, from patient to case basis, you have to decide brachy dose for recurrent tumors. This is our protocol, right or wrong, but this is what we follow. And if we have to do brachy alone for small tumors, then our dose is 44 gray, 11 fractions, or 6 days by SDR in 2 fractions a day. For boost, we give 21 gray to 24 gray for based on the size of the lesion. For T1, T2, we give 21 gray and 7 fractions. For larger lesions like T3, T4, we are also doing like for T3, T4. For T3, T4 tumors, we are doing like 24 gray in 8 fractions or something, or 4 days time. Just to show now these different sites, this is one gingival growth, which was on CT scan. It was not very deep. The depth was not much, so we thought we can cover by the mold. So this is how the mold was prepared, with the 2 catheters on both sides, and you can see the dosimetry, the red color dosimetry. It was covering the depth very well, and therefore it is an easy treatment. It's not doesn't require much invasiveness, which people are afraid of. So it's a simple treatment. If the lesion is superficial, you can just prepare a mold and you can deliver the dose. There's one patient who had a residual disease after the EBRT, so after the 70 gray. So we took this patient for the further treatment with brachytherapy, and you can see this the dosimetry. We had 2 planes in the thicker lesions, and then the lower down we had just 1 plane, so that we can cover. Nowadays, you know, to strictly follow the Paris techniques, because earlier we were following the Paris technique, but nowadays with the help of computerized planning system, you can adopt different arrangement of the catheters based on the thickness and the various dimensions of the tumor. So as you can see here, this red is the isodose, prescription isodose, and you can see the underlying bone is getting a very less dose. The tumor is being covered very, very well. In fact, another patient who had a lesion at the angle of the mouth, and for such lesions, the surgery is not a very good option, because when you do surgery, there is a narrowing of the mouth, and patient's quality of life is not very good, because they won't be able to speak, they won't be able to masticate the food, and they have a very difficult, difficult in having all these functions. So therefore, in this site, brachy is very, very important, and one important effect which people are afraid that in surgery there will be a shortening of the stoma, and there will be a difficult opening the mouth. But with brachy, all these complaints are not there. As you can see, this patient, the same patient during the follow-up, and there is some slight discoloration of the skin, which is fine, because the patient's tumor was coming right onto the skin. So we deliberately delivered the dose onto the skin, and therefore I was happy that I was able to deliver a good dose to this shows that the good dose were delivered at the skin surface, which will be very important for the control of the tumor. And if you can see the same patient, the mouth opening is very, very good. In fact, same patient, if this patient had undergone surgery, then the mouth opening would not be that good, and even the cosmesis and the appearance will be very, very awful. But with brachytherapy, the tumor is absolutely gone. the mouth organ is very good. Patient doesn't have any compromised function like speech or mastication, anything else, So that way, it is a lot more comfortable to the patients if you brachytherapy. So that was lip. And now we come to the lateral word of the tongue, which is very common in India. Just so this patient had a T1, T2 tumor on the lateral word of the tongue, going right up to the undersurface of the tongue as well. So how do we perform brachy for these lesions? Although had I had time, then I could have shown the video, but I will just briefly show the procedure. The first step is that after cleaning, draping, you demarcate the lesion. As you can see you can see the lesion, and then you mark up 1 to 1.5 or on the lesion so that you can cover it very well. You can see the dots, which is the area to be implanted. Once you mark that area, then you can choose the distance, as I said, like 1 to 1.5 centimeter from the intercatheter interplanar. And this is how we put the catheter from the transcutaneous route. We take out the needle into the tongue, dorsum of the tongue, and from there we introduce insert the catheter and then take it out from the same transcutaneous. So this is how you end up putting the inserting catheters in the tumor. And as you can see, this is the arrangement. You can very nicely have covered the tumor. In fact, you trap the tumor from all around. And so therefore, this dose will be spreading right across the area which is having microprecies. And I made sure that I insert one catheter in through the tumor, because that is where you need to deliver a very, very high dose. So around the catheter, you will have 2 or 3 times higher dose. It will be like 120 gray, which you need at the center, because central parts are usually necrotic, hypoxic. So even though there was bleeding when I inserted this catheter, but that is very well required, because you should be right there into the tumor, heart of the tumor. So you should not be afraid of putting the needle into the center of the tumor. This was the dosimetry. I will not go into details, but what you can see that the dose is spilling onto the mandible and teeth, but that is without the seal. We usually, when we treat, we put a shield between the mandible and the tongue. I did not put the seal here because once you put the seal, then in CT scan there will be a lot of scatter. So I did not put the seal here just to show the the clarity of the image. But when we treat this patient, we usually put a thin lead sheet between the tongue and so therefore this isodose will be separated from the mandible. So you can see the nice coverage of the tumor here. And you can see in multiple. Nowadays with CT-based planning, you can see the tumor and you can see the OR, you can see the dosimetry, you can play around. If you can titrate the dose with optimized tools, you can shape the dosimetry as you perceive. So that's a lot more comfort with the SDR optimizing tools. Another patient who had a base of tongue lesion, which is a little difficult from there, and I would suggest the youngsters that do not start from the tongue, base of tongue. You start doing from the lip, buccal mucosa, and the little border, because then you will be gaining confidence, and keep the base of tongue as in reserve for a later stage, because these are difficult implants. Once you get over the lip, buccal mucosa, then you'll be confident in performing these. So, but of course, with the experience, you can do even the base of tongue. As you can see, right across this is the epiglottis, and you're touching the valvula, epiglottis. With this kind of arrangement, you are going right up to the base of tongue with brachy. People think that we can't reach there, but it's not that difficult, And you can see the dosimetry in the base of tongue, and all other like remaining tongue, the other areas is not getting very high dose, So you can spare the OAR, and you can still deliver a high dose in the tumor bearing zone. Again, one of the slides from the same patient. This is one procedure I would like to share with you, because this is a patient who had a residual node after the 70 gray of EBRT, and it was a fixed hard node which was not operable. And under normal circumstances, people will take this patient either for chemotherapy or for some targeted therapy, or maybe they will explain prognosis, because it was a 3 centimeter kind of node, maybe slightly larger after the 70 gray node. So for these patients, if you don't do something, with these patients, even if you give chemotherapy, they are not going to survive. They will die within like 6 months time and all that. But we took up this patient because the primary tumor responded very well. It is only this one node which was there. And although people do not do brachy for node because there are not many studies in the literature, but for me, it is just a mass of the tumor. It's a mass of the cluster of cells which if I can treat the primary tumor, the same cells which have migrated to the node, so why won't they respond? So I believe the simple philosophy that this is again a mass of the tumor, cluster of cells. So why wouldn't it respond to chemo with brachytherapy? So to escalate the dose, because after 70 gray in head and neck, it is a really problem. You can't go beyond 70 gray. You will have a lot of complications because there's a vessel underlying this. And even brachy is difficult because you have a vessel just sitting below the node, it is fixed node. So you can end up the carotid vessel, you can end up puncturing the carotid vessel, and it can be catastrophic, and it can be a disaster. But with experience, you can do all this. And let me tell you, if you can deliver dose to this kind of node, this will definitely respond because it was a larger node in the beginning. But I'll just show you that how did I did. I did it under Doppler guidance, just like you do the Doppler in the DVT cases. So with this Doppler, I could see the vessel. This is vessel. You can like this colored picture. This is the vessel, and this is the node. So once you see this, then you are confident, and you can see the ultrasound is a very good tool to see the steel needles. So you can see the needles, you can see the vessel, you can see the node. So all these three structures are visible with the help of Doppler. So then it's easy. And this is how we put the catheters then, avoiding the vessel. And then we do the CT-based angiogram. In fact, for IMRT, we'll do so many things. We do sometimes do 4D CT, and we do like all sort of plannings and colored, deviates pictures. But brachy, we don't do much. We don't like to spend time. But let me tell you, if you spend a little time, brachy looks equally fancy. Like if you can see this, this reddish tumor, the blue is actually the carotid, vessel. And these are the catheters, and you can see even the medulla. You can see all the structures, and we could see even we could measure the dose even to the vessel as well, So the vessel was not getting very high dose, So that's how we avoided the vessel injury, and we covered the nodal by brachy very well, But anyway, I will not go in details because although I have a video on that. So after these procedure, when you have to remove the implant, which is equally important, people think that doing is more difficult, removal is not difficult, but removal is also a little tedious in these patients. But if you follow a protocol, then it's not that difficult, So you have to plan the removal accordingly. Plan in such a way that it should not come on a Saturday or a Sunday or a holiday, because you need helping hands when you remove the implant, and especially sometimes you can have some sort of complications like in bleeding and other things, So it should not fall on a odd hours or odd day, And you should do a good planning that which catheter to remove first and which catheter is likely to bleed when you remove. So once you do a little bit of homework, then it is really not a problem. But the objective of good removal, is that to prevent a complication. If not prevent, then you can minimize the complications by good planning. And in some patients, you will have some complications. It's not that you will not have complications. So you should know how to manage the complications. So prevent complications, minimize complications, and to manage the complications. This is how you should handle these patients. And what complications? These are the complications which can happen during the removal of the implant. For example, bleeding is one of important and principal complications which can be sometimes, if not dealt well, it can be very disastrous. But if you tackle it well, it's not going to be that difficult, So bleeding is one complication which you should keep in mind and prepare accordingly. Aspiration, these patients sometimes might aspirate and might have aspiration pneumonia, or might even have respiratory blockade and all that. So you must keep in mind, you must keep the suction ready, so that whenever there is a risk of aspiration, you can, in fact, you should do suction even before patient aspirate. And as I said, the bleeding can block the airway passages, and therefore you need to keep the suction ready so that bleeding doesn't go into the air passages. Pain can be another complaint, because these are painful sites, And if you keep the catheters for like 5 to 7 days in situ, they will definitely have cause pain due to inflammation caused by the radiation and caused by simply the trauma itself, So they will have a pain, and therefore take care of the good, by giving good analgesics, even though it might be sedation or combination of the analgesics, And Sometimes it might be difficult to locate the catheter buttons because if the base of tongue, sometimes you may not reach there because when the patient was treated, the due to inflammation, the patient might not open the mouth that well. So there could be some difficulty. So you must keep all these complications and difficulties in mind before you take up the patient for the removal. So how do we do that? As I said, although sedation is required, but do not do a heavy sedation because these patients need to be cooperative. Like when they aspirate, you need them to cough out, or you need the reflexes to be intact, especially the cough reflex. Because if patient has an intact cough reflex, they will usually cough it out. Whatever spillage of the aspiration, or there is a bleeding. They will usually cough it out. So the reflexes might be intact, and if you give heavy sedation, the reflexes might be compromised. So do not heavily sedate them. Although you can give mild anxiolytic, like you can give midazolam kind of thing, and then you should give good analgesia even before you take up the patient for like removal. You treat them well with the good amount of analgesics, and patients should be alert and cooperative. Explain them about the process that you might experience a little pain, you might have bleeding, so you might have to press and all that. So you have to tell the patients a little in advance that this is how it will happen, so that they do not have any fear in it. Because when you take this patient for removal in the OT or minor OT, they might be just feared of. Patients should not be hypertensive when you check the BP before the removal, because if patients are hypertensive, that will have a tendency to bleed the patients more. So ensure that the BP is normal, so that the bleeding, even because when you remove, there might be some bleeding. But if patients are hypertensive, BP is like on the higher side, they will definitely bleed. And keep your anesthetist informed when you remove, because sometimes you need their help when during putting like endotracheal tube, if there's a blockade or respiration, and even the surgeons when there's a bleeding, so they can come and help. It has happened once with us that we have to call the surgeons, but you should not hesitate, because it's a teamwork. When they have problems, they definitely call us. Sometimes if their margins are positive, they will definitely call and keep please give an early date because this patient has little close margin. So it's just a mutual understanding, mutual help we take from each other. This is another technique which I just mentioned because I know this is not being really performed in worldwide, but this is one good technique which we do at our institute, although not very often, but in selected patients we do that. This is perioperative or intraoperative brachytherapy. These are two different terms. People usually confuse them, but they are two different terms. Perioperative, when you deliver the brachy in the perioperative period, which means after the surgery, like 4 or 5 days after the surgery, when the healing has already taken place. And operative means you deliver and complete the process of radiation during the surgery itself. I mean, the brachy will be delivered even before the surgery is complete. So this is called intraoperative brachytherapy, and this is done for patients who are like having post-RT recurrences, and when you operate them, then there might be some issues regarding closed margins or the seedlings of the tumor bed, and therefore you do not have the luxury of giving the further radiation because you only given like 70 gray before. So you need a conformal technique so that you can deliver during the surgery or in the perioperative period. During surgery, because you can displace all the normal tissues away from the tumor bed, and you can deliver those to the tumor bed. And as you can see, the tumor coverage by the brachy is very good. The adjoining organs are not getting really any dose here. This is the intraoperative brachytherapy, which you place a small applicator based on the tumor bed, and then you connect it to the machine, and you treat the patient there and then in the operation theater. So therefore, the OT has to be modified into the intraoperative OT. And we have the IOSDAT facility with us, which means we transport the same SDR brachy machine into the operation theater. Our operation theater has been modified into the walls are thickened and they strengthened in order to have the SDR treatment there. So it's just the minor modification you have to do in your surgical OT, and then you can take the same portable SDR machine to the OT and treat these patients there and then. So this is again for patients who have recurred after like post surgery, post RT, and you have some margin issues during this surgery. Anyway, I think so. I will not go in details because I think it's already the time. Just to summarize, the brachytherapy in head and neck cancer is indicated in early and advanced stages. Both. Let me just put it again that it's not only the early lesions where the brachy is required; it's required even for advanced stages as well. And as I shown you, brachy provides excellent local control, excellent survival with the minimal toxicity, which are comparable to surgery. In fact, better than surgery. If you see the toxicity, if you do a tongue implant, your tongue remains intact. If the surgeon operates on a tongue tumor, they will usually remove 30 to 40%, maybe half of the tongue, So how can you compare the quality? The quality will be definitely better with the brachy in these cases. It is a very good option for the recurrent tumors. They are very limited option for recurrent head and neck tumors, but brachy is a good option. In fact, this is one of the standard treatments for, and it's only the salvage, the curative option for the recurrent tumors in head and neck region. IMRT brachy, usually people see both the techniques as rival techniques, but in my opinion, they should not compete with each other. They should be complement each other. You can combine IMRT and brachy. Both, for example, if in the beginning the tumor is large like T3, T4, give a like 50 gray in the beginning with IMRT, shrink it a bit, and then give final assault by brachytherapy so that you can deliver the dose right up to 80 to 85 gray, which will definitely work for these patients. Because if you do IMRT alone, 70 gray, but if you combine IMRT and brachy, I'm sure you can push the dose up to 80, 85 gray, which I normally do. So IMRT brachy should not be placed against each other, and they should not be fighting against each other. They should combine. They should complement each other. And I feel the best way to start brachy is to begin with doing head and neck brachy, because we sometimes keep thinking that okay, we'll do. But I think somewhere we have to start. Maybe we can start from lip buckle, because gingiva, and then like from tongue, and then base of tongue, and other difficult sites. So I will stop here because I can go on and on. Dr. Salin, if you permit, I will stop here, and I'll take questions then.
Thank you so much, sir, for that very, very wonderful talk. And you were so very right when you said that brachytherapy as an option for treatment has not been exploited as much in head and neck cancers as it is done in other sites. And rightly, you will also agree, sir, that brachytherapy in head and neck cancer is so much operator dependent. So an expert putting in the needles, it depends so much on that. So that is one of the issues maybe, which and now with the treatment planning systems and the computerized planning systems that we have, we can optimize the doses. So brachy has become easier. But what I wanted to ask you, there are a few questions, we'll discuss that. But I just wanted to ask you, like you said, in head and neck cancers for locally advanced T4 lesions, has there been any role of adaptive brachytherapy like we do in prostate or other sites?
Role of what
adaptive brachytherapy.
Okay, adaptive. Oh, yes. See, usually these patients require a dose of like 50 to 55 in the beginning, so that we can shrink the target. And once there is a shrinkage of even like 40%, 50%, then it's easy to perform the brachy implant in these patients. And so therefore, you can adapt the volume of the brachy implant as per the shrinkage and the response. So definitely that's the purpose of giving the EBRT in the beginning, that you can make them shrink and make them recede, so that you can do and therefore if you do the brachy, as I said, 24 gray and 8 fraction, that would be equivalent to like something like 30 gray, and 50 gray are only given by EBRT, So you are pushing them to 80 gray, which you normally can't do by IMRT. I mean, it's not that easy to push the dose to that because in IMRT the dose has to go from somewhere, In brachy it is coming from within outwards, So I really push the dose up to 80, 85 gray. And after that, it's not my job, because our job as an radiation oncologist is to deliver the highest dose to the tumor and immunodose dose to the tumor. Rest is up to the biology of the tumor. You can't control the tumor biology, But I think that's the job we have to do,
Right. So there's a question, somebody is asking for brachytherapy in cancer of the soft palate, early stage.
Right, yeah. So first of all, soft palate tumors are not very common, frankly speaking. Usually the tumors like in the base of tongue, they will encroach on the soft palate, It's not that easy to perform the soft palate implant, I have developed my own bit techniques. I usually do not take the same approach like from transcutaneous, because then you have vessels, and then you have a risk of injuring the vessels. I usually go through the oral route and put some catheters there, and then the catheter come out to the oral cavity, but it's all right, I don't mind that, but it's not that common. I have not done many soft tissue implants, soft tissue, soft palate implants.
Soft pellets.
But yes, it is possible. We can do that, yes.
Okay. And somebody is asking for base of tongue. When you do an implant,
Yes.
is tracheostomy required?
Not for all patients, frankly speaking. Not for all patients.
I
Yes.
think I'll ask Dr. Shalin. I can see Dr. Shalin has joined us. Welcome, sir. Dr. Shalin, please. You can unmute yourself, please.
May I request you, Dr. Ghosh, to please conclude the questions of our people. There are lots of questions there, and you
So
want
one
to
more
finish those
question.
questions? Yes, please. Yeah.
Okay,
Yes.
okay. Please.
Yeah. The outcomes you have observed in brachy of head and neck residual nodes after EBRT. So you've already discussed that, but I think they want to know your experiences about it.
Well, this patient, we did a PET scan, frankly speaking, because patient had a hard fixed node, which had a fibrotic component as well post-party, So to assess the response, PET scan may be the technique which can, the modality which can let you know. The SU is different. It was from 9, it came to like 2.5. The patient didn't grow in the size. Patient had a syncase in the node side, although it did not disappear. But patient died of the lung metastasis, not with the this node disease. So I was happy, and when you do a new technique, you should not worry about the results, because when you are developing a technique like this, I'm sure not many people are doing nodal break, So I was not, frankly speaking, I was not afraid of the results, because if you are afraid of results when you start a technique, then you probably can't master the technique, So I was, frankly speaking, I was not afraid of the outcome, because I knew if I deliver a
Yes,
dose,
sir.
it
Very
will,
rightly said.
it might
I will
respond.
now request Dr. Shalin to put in a few words, his experiences.
Thank you. So there's another question on dosimetric parameters,
Yes,
but I think
sir.
that can be taken just now. I
Right.
have a thought on this, sir.
What?
We had audited, as you probably, about 30 years ago, 25 plus years, nearly 30 years ago.
Right.
Tata Hospital, where I did residency, they have a very active brachytherapy group.
Right.
And of course, we have Professor Balawat Saab, and we had A.J. Chaudhary. They were grandmasters, but
Right.
Dr. S.K. Srivastava was also very prominent, and Madam Dinshaw also did it. So
Right.
interestingly, I looked at head and neck cancer and audited something like about 80 to 100 patients done over the past 10 years. Most have received external radiotherapy, 40 gray, 45 gray, followed by radical implants. They were typically using low-dose iridium. I was rather quite surprised to see poor tumor controls in T1 and T2. These were down to about 40%, 35%, completely way off the mark compared to the European 85, 90% T1 radical brachy outcomes. I had no good explanation for that. A lot of the patients were anterior tongue. They seemed to do much worse. Buccal mucosa was better, but if you look at tongue, anterior tongue, floor of mouth combined, it was quite disconcerting. I did not have a good explanation, and that has actually resulted in that if we have an early disease, we tend to tell our patients, please go to a surgeon, get it out. A partial glossectomy with as much preservation of organ function as possible. We'll follow it up happily with teletherapy. And that has been a practice. May I ask you, have you, for instance, had the occasion to compare your selected patients with brachytherapy compared to those who had probably similar staged surgery followed by external radiotherapy to the surrounding areas and the drainage sites, if that has happened? Otherwise, I still remain intrigued by this biology. Please, your expert views, sir.
Very, Dr. Salim, very difficult question you asked, Anyway, let me just tell you. First of all, the head and neck brachy has a slight learning curve, as compared to the like breast brachy or the cervix intracavity, it has a learning curve, So one has to have patience while doing the head and neck implant, to be very honest, because that is important for any, just like a laparoscopic surgeon has to have some patience in the beginning, They cannot be 100% accurate right from the beginning, There is a learning curve during the even the some of the newer surgeries, So in head and neck brachy is a site, I agree, it's one of the relatively difficult sites across the body. If I have to enumerate, like sarcomas are easiest one, the in cervix and the breast and all these, These are difficult sites, There is a learning curve. Initially, you'll have these kind of issues, like results may not be as good as one has to think, But let me tell you the second part of your question, which is very pertinent, that if a patient with T1 or T2 tongue lesion comes to you, what would you do? Should you refer to the surgeon or should you just proceed with the implant, Now, if you see these kind of patients coming to both sides, surgeons, even though are aware that yes, brachy is a modality which has been performed across the globe, and there are literature studies as well, but they will not usually refer the patients to us because these patients are usually recruited to the surgical modalities, specialties. So honestly being, they will not refer these patients to us as well. But being honest, I still ask the patients to choose. I give both the choices. And our team, in fact, the head and neck team, gives both the options. You can choose surgery, you can choose brachy. You tell both the pros and cons. And let me tell you, in some of the head neck, the tongue tumors, when the surgeons operate, they end up removing the half of the tongue. Now, with the half of the tongue, you can explain that okay, you'll have a good quality of life, but we know that if you remove half of the tongue, hemicolectomy, you can't have the same quality of life as in brachytherapy. So it is just way how you explain. Sometimes when the surgeons are not willing to operate, like they are going on vacation, they will explain different words. When they are willing to operate, then they will explain a different setting. So it's just the way how you explain them. But usually I tell the patient honestly both the pros and cons of both techniques. But let me tell you, some patients will choose brachy. If you explain them well, some patients will definitely choose brachy. And I'm happy, even if 2 out of 10 patients will choose brachy, 8 goes for surgery. It's fine. I don't mind, because small tumors, both are fine, but if you compare the literature, there is not a hardcore randomized head-to-head trial comparing surgery versus brachy, and it will never happen. Let me tell you, it will never happen as well,
Sure.
So if there are not trials in favoring surgery, then why do you choose surgery then? The same way I have trials showing 85%, 90% local control in T1 lesions of the buccal mucosa and tongue, I would quote that literature. So that way I'm fully entitled to practice my technique, which has the results evident in the literature, favoring my results, So lack of literature does not mean surgery or brachy will be the treatment choice. Both will be the treatment choice based on the conditions, circumstances, expertise, doability, feasibility, practicability, whatever all you can say, But this is how we choose. I mean, right or wrong, this is how we choose patients. As far as local control is concerned, now, of course, although I'm not very active in head and neck area because my colleagues are doing the EBRT based table, I do selective cases of brachy because not many people in the department are doing after Monty's exit, not many people are doing head and neck brachy, So that is where I chip in for head and neck area. Otherwise, this is not my area of interest, But since others are not doing, I have to do it, But let me just tell you, in T1 tongue tumors, which is sort of competing rival modalities for surgery in brachy, I achieve usually 80-85% local control, and I'm happy.
Amazing.
I'm happy.
Dr. Ashutosh Mukherjee is also very
yeah, could I
aggressive.
come in, sir?
Yes, Ashutosh. Yes, please. Good to see you.
Ashutosh, please.
Good to see
Hello,
you.
sir. Hello, sir.
Hi.
So, sir, regarding this question on T1, T2 tongue, we did a little background check on this. We wanted to start brachy over here for this. So what we found in literature is there was an interesting Turkish paper. I'll share it.
Right.
That in T1, nearly 15 to 20% of patients have occult neck nodes.
Right.
While in T2, it goes up to nearly 35%.
Right.
So this Turkish group, what they did was they did the brachy and in the same setting, the surgeon would do a supraomohyoid neck dissection and send for the analysis, the pathological analysis. If the node was positive, we would convert that into a modified radical neck dissection of the ipsilateral side.
Right.
And they would then consider external beam radiation of the neck, and they would match the dose to the 50% isodose line of the brachy application.
Okay.
So this is how they treated tongue, because in tongue now, with the concept of DOI, penetration, depth of invasion, tumor thickness, if we do brachy upfront in T1 T2 tongue, we lose out on these information, and perhaps then we undertreat the neck. So I think in tongue we should treat the neck. We should not forget to treat the neck.
Okay, fine. Well, if you see the Turkish paper is one paper, but let me quote, I can quote 5 more studies where T1 tongue tumors have been treated by brachy alone. Let me just tell you. I'm talking only the lateral, anterior and lateral border of the tongue, not base of tongue, Okay. T2, I agree with it. For T2, you need to combine EBRT or brachy, or you need to do surgery, We explored a couple of options in our patient level, because you need to identify which are the patients likely to recur in head and neck area, which are likely to have positive, So when we do brachy, we ask our surgical colleagues to do, the sentinel node biopsy for these patients. They can inject the same material like in breast, and they can find out, Although this didn't take as a shape of a study, but we explored in certain patients. This is one way one can deal with the nodal disease, just like in breast or any other area. Doing a sentinel node biopsy, and then if they are positive, you can proceed. You can treat neck node. At most, that yes, nodal disease might be a problem, and you have to tackle the node somehow. So this is one way. But I feel in T1, I'm comfortable. I don't blindly follow the literature, frankly speaking. If I'm happy in my own center, because patients in a different center, different countries are different biologies, So I really do not push myself and don't follow the literature blindly just because some study has been done. If I am happy with my patients and my technique, and I know that 10% nodal recurrence rate is fine in T1 tumors, it is all right. Because even after surgery, 10% recurrence rate will be there in T1 tumors. So that way I'm fine. But yes, there is a room for improvement in this area, that how to deal with the nodal disease and all that. People nowadays have a different thing like PET scan, they have like ultrasound neck, they can do all these kind of methods to identify the patients who are likely to have a nodal disease, So that way you can deal with the nodal disease if you suspect the node to be positive or to be harboring the disease, But yes, this is one area where but let me tell you, that's not deter us from doing brachy, because we know that you still need to treat that primary area either by surgery or brachy, So one should not just feel that, okay, there might be risk of node, so we'll not do the nodal brachy, We can do a brachy for primary and deal the node separately by either all these methods. You can do surgery, you can do EBRT, you can do imaging and find out all patients like positive, negative, But yes, that in area where we can proceed to study more,
I think Dr. Rashi has a question.
Yes,
Dr. Rashi?
Unmute yourself, Dr. Rashi, please. Unmute yourself.
Dr. Rashi wanted to know, how do you treat the non-healing ulcer after brachy?
Okay. Maintain a good hygiene and analgesics, local applications like sometimes steroid applications and analgesic applications. Simply, it takes time, frankly speaking. There is no real remedy for the ulcer to heal. The only thing that we have to prevent some of the complications like infection may not be there. So maybe a course of antibiotics and a good analgesics and keeping the hydration well, analgesics, anti-inflammatories in specific, It takes time. If we can maintain the hygiene, good, but it
I
takes
think
time.
it is at least maybe up to 6 months.
No, in my experience, not 6 months, to be very honest. It takes just 2 months. But I'm telling you, don't worry about see, if a patient undergoes hemicholosectomy, you can expect what kind of quality will be there. These patients might, even if like 6 months there, but after that they'll be all right. So I don't mind. This is just a small price patient have to pay for keeping their tongue intact, keeping their organs intact, And maybe once you grow in experience, then this might go down, because nowadays you can you can really save the dosimetry. If you know that the adjoining buccal mucus is getting a little high dose, you can optimize, you can reduce the dose if at all it's going there. Keep a seal between the mandible and the tongue so that the mucosa on the mandible side doesn't get a high dose. But yes, this really doesn't bother me much, frankly.
So there's just one question about the plan evaluation,
Yes.
dosimetric parameters, and what are the parameters we look into?
Well, I first see the tumor. My CTV should be covered well, 100%, should be all right, And I usually that is divided by buttons because you can't see the tumor in the CT scan, to be honest. So but I know when I was in the operation theater doing the implant, I palpated the tumor and implanted the catheters. So my catheters are actually the kind of clips and kind of tumor boundary for me. So if my buttons are being covered very nicely in 100% isoscar, that means I am there in the tumor itself. That's one parameter for the tumor coverage. Rest, and then I see that how much the inhomogeneity, like those homogeneity index, I see that the 150% lines should not be joining with each other in 2 or 3 places. In 1 or 2 places they can join, but they should not be joining. 150% lines isodose should not be joining in all the catheters. That will happen if you keep too much distance between the catheters.
Mm-hmm.
So that is one sector. For OR dose, I know there's no OR nearby, so I don't really I don't waste time, frankly speaking. You can measure dose with parotid, you can measure dose with mandible, I know, but it is just a matter of calculating and measuring dose there. But I know most of the time it is usually under control. So that's how I assess.
Thank you, sir. Thank you so much. It was a very interactive session. It was a pleasure having you. Very informative talk. I hand over.
Do you have some question, Dr. Sally?
I'm perfectly fine, sir. Thank you so very much for your time. We are delighted to have you, sir, on board. Dr. Radharani, may please conclude. Thank you.
No, I was asking Dr. Rashi and Dr. Shalin to conclude, sir.
Okay. So I've spoken. Dr. Rashi, you have something to say and we'll conclude then.
Dr. Surabhi.
Okay,
thank you so much. Thank you so much, sir, for being here on behalf of UPRI. I would like to thank you so much and giving your valuable time for this wonderful talk. Thanks once again, sir. Thank you, Radharani ma'am. Thank you for giving your time. Thank you, Salin sir. Thank you, Dr. Rashi, Dr. Ashutosh, and every participant. Thank you so much.
Thank you very much. Thank you so much and good night.
Good night,
sir.